One of my favorite vasculitides, juvenile dermatomyositis. This obviously affects the skin and the muscles, as you can tell from the name. Girls are more commonly affected than boys. Has a bimodal distribution, so grade school age kids and then teenage kids. It's characteristic by a rash with proximal muscle weakness. You are more likely to have rash without muscle weakness than you are to have muscle weakness without rash. The classic heliotrope rash is the dark circles you see under the eyelids. That same color you're going to see above the eyelids. It's supposedly kind of purplish, but it can be difficult to tell. You see Nailfold capillary expansion because you've had death at the capillaries and the remaining ones are larger than usual. You can see a seasonal clustering. You can see a geographic clustering. We don't know why. Gottron's papules. So, the rash in dermatomyositis is over the knuckles. The photosensitive rash in lupus spares the knuckles. So both of these have rashes on the hands, but they're very different. You can see cutaneous nodules. Usually this is very latent disease or is a sign that they've had disease previously and gone into remission spontaneously. Proximal muscle weakness is more than distal muscle weakness, so they can grip just fine, but they can't raise their arms over their head. Skin ulcerations are rare and can cause GI vasculitis, which has a very poor prognosis. You can have perforations of the bowel leading to death. Dysphagia and dysphonia are very common. You have trouble swallowing pills. They talk in a high nasal voice. Unlike adult polymyositis, there is no increased risk for malignancy in children. You can see a characteristic pattern of inflammation in the muscle, getting MRIs of the thighs. There's segmental things where some muscle bellies are completely white and some are completely black, and they're next to each other. It's not a diffuse myositis, it's a segmental myositis. You diagnose it with having one of the characteristic rash, either the heliotrope rash or the Gottron's papules, the rash over the MCPs and PIPs, and two of the following for probable diagnosis: symmetrical proximal muscle weakness. We have a whole scale of tests that we do specifically to see how long can they hold up their head, etc., that we use for both diagnosis and treatment. And increased blood work, CK, aldolase, LDH, transaminases, all will be up during periods of active myositis. For definitive diagnosis or academic center diagnosis, you do EMGs or muscle biopsies. As a private pediatrician, I rarely do these because they are painful for the child, expensive, and delay therapy. You also can get a diagnosis with just these two, which they almost always have. The treatment, initially you give steroids. You can either give this orally or through IV. You give IVIG once a month, particularly in the younger children. There's some debate about how useful it is in the older children. You usually start them on 1 DMARD, hydroxychloroquine. Sometimes you add a second, methotrexate. Sometimes you'll add or substitute a third, such as mycophenolate. Physical therapy is important to prevent joint contracture. Sun avoidance is important, as in pretty much all of our autoimmune diseases. And for refractory cases, we're beginning to use rituximab, which knocks out your CD19/20 cells, and also TNF inhibitor therapy.